Hey guys, I'm Mustafa and this is my first Mustat. So today I'll be talking about an ECG I came across in this past week. It was basically an elderly female that came in complaining of chest pain. So when you look at this ECG, the first impression is, oh shit, what's going on here? Because it looks like there's a lot of things going on. So the goal today is just to try and simplify it and try to break down what is happening in this ECG and hopefully learn something from that. So what's the first thing we're going to check for? Name and date of the ECG. I've obviously redacted that information, but then the second thing we'd look for is the rate and rhythm. So with rate, we're going to look at the number of Curious complexes and times it by 6. Why? Because the ECG measures 10 seconds, 10 times 6, 60 seconds. So I'll do the maths for you. It's 19 times 6, which is going to equal to 114. The rhythm is sinus as well. How do we know that? Because we've got positive P waves in the inferior leads, and we have a negative P wave in AVR, and that tells us that this ECG is in sinus rhythm. Cool. Obvious abnormalities, obviously, in this ECG are your ST segments and your T waves, which look really strange in all of the leads. So I like to have a bit of a system with it, and to try to break things down, I use an anatomical approach. So I look at your inferior leads first, which are going to be your 2, 3, AVF. Then look at your septal leads, V1, V2, your anterior leads, and your lateral leads, right? And then finally your high lateral leads. So looking at your inferior leads, we can see that there is ST elevation, right? This is our isoelectric line. We can see that there's ST elevation of over 1.5 millimeters in lead 3. We also have ST elevation that can be seen in AVF. So we've got ST elevation in 2 contiguous leads, and that means that we are fulfilling STEMI criteria, right? Then we're going to go to our septal leads. So on our septal leads, something interesting is happening, which I will discuss a bit later, but that's your isoelectric line. So we can see that there is ST depression, right, in your V1 and V2 across through to V6. Interestingly, though, it's horizontal ST depression in V1 and V2, and you've got upright T waves, right? So just bear that in mind, that you've got upright T waves V1, V2, V3, whereas in V4 through to V6, you've got these inverted T waves, right? And then finally, we're going to look at our high lateral leads, and we're going to see that there is some ST depression, which I hope you guys can see. I'm going to draw the isoelectric line there, and below that, you can see that that ST segment is below, right? So this is all confusing, because how do we make sense of everything? We've seen that, yes, there is an inferior STEMI, but before we go further than that, I'm just going to give you a quick anatomy lesson. I know nobody likes anatomy, but I think it's relevant with STEMIs. So this is just a diagram that depicts the vasculature of the heart, and obviously you've got your right coronary artery and you've got your left coronary artery. So we're just going to focus on the RCA for now. So it comes off from your right coronary sinus, it runs down, and then it gives off this marginal branch, which is going to supply the right ventricle, and then it wraps around the heart and comes here and gives rise to our main talking point today, which is our posterior descending artery. The interesting thing about the posterior descending artery is that in 80% of people, it arises from your right coronary artery. So you've got a RCA dominant circulation in 80% of people. In 15% of people, it arises from your left circumflex, which is, remember, this guy here that wraps around. You have your LAD that runs down there, and then you've got your circumflex that comes here. And in 15% of people, they've got a left dominant circulation, and then in 5% of people, they've got a codominant circulation, right? So this is relevant for 2 reasons, right? The first one being that inferior infarcts often accompanied by right ventricular infarcts in 40% of people, and posterior infarcts in 20% of people. So depending on where the clot is sitting, you kind of have to figure out, is this a left dominant circulation or right dominant circulation? And you can actually figure out exactly where that clot is, right? The second reason is that we can actually tell if the STEMI is a left or right dominant circulation, depending on changes that we find in an ECG, which I'll briefly explain to you guys in a bit, right? So what do we need to, the take-home point from this is that if you have an inferior STEMI, the important thing to do is you need to look directly at your right ventricle as well as your posterior portion of the heart. So how do we do that? So we need to do something called a V4R. So that means you move that fourth sticker electrode from the left side of the chest, which would be in the midclavicular line in the fifth intercostal space, to the midclavicular line in the fifth intercostal space on the right hand side. So basically from the left to the right, and then we get something called a V4R, right? And what we're going to look for is ST elevation over there, and we actually don't see any ST elevation over here. It doesn't meet STEMI criteria, so we don't have a RV infarct. We're then going to move the leads, your V4, V5, V6, to the posterior portion of the chest, and we're going to get our V7, V8, and our V9. And here we can actually see that yes, we do have ST elevation in our posterior leads. So we have a posterior-inferior infarct. Okay, cool. Things are coming together. We're making sense. So let's go back to our original ECG, right? So let's summarize what we found. So we've got a posterior-inferior acute ST elevated myocardial infarction. Why? Because we've got ST elevation in the inferior leads, plus we've seen that there's ST elevation in our posterior leads, right? That's the first thing. The second thing is that we can find that we have a reciprocal ST depression in our high lateral leads, right? So this ST depression that you see there and that we see here, that and that, is reciprocal to the ST depression, the ST elevation in our inferior leads, right? So these guys are reciprocal to one another, right? The third thing is that we have a reciprocal ST depression in our lateral leads or anterior leads. So that this ST depression that we're seeing over here, right, that and that and that, is reciprocal to the posterior STEMI that we have, right? So you're having an infarct in the posterior portion of the heart, and all of that ST elevation that's being seen at the posterior portion, if we had those leads at the back, when the leads in the front, you're seeing the mirror image of that, and that's why we're seeing this reciprocal depression over there. And then the changes that we're actually seeing here in V1 and V2, horizontal ST depression and peak T waves, are actually the posterior MI being seen from the anterior portion of the heart. And I'll make a video about that at a later stage. So then the last thing we want to find out, is this a RCA dominant circulation, or is this a left circumflex dominant circulation? And the answer is that this is a RCA dominant circulation. Why? Because the ST elevation in standard lead 3, right, this degree of ST elevation is greater than that degree of ST elevation. So 3 is greater than 2. It's greater than 2. And then you also have reciprocal ST depression in your high lateral leads, which you don't really get with the circumflex circulation. Circumflex circulation, 2 will equal 3, and you won't have that reciprocal depression, right? So basically, in summary, we can figure out that this patient has a clot that is sitting distal to this marginal branch. Why? Because we don't have our RV infarct. So it's probably sitting somewhere about here. And it's infarcting the posterior portion of the heart and the inferior portion of the heart. And that's why this patient is having all of these changes in the ECG. And I think it's quite cool that we can see all of that and get all of that information just by putting a few stickers in the chest and running an ECG. So I hope that helps. Hope it wasn't too long. Please feel free to ask any questions in the comments.